go live and confirm. Just wait, Radhesham sir, please. Backend कौन मुजफ्फर है ना, कौन है?
Sir, Muzaffar, just give me 2 minutes.
Yeah. No.
Good evening, sir. Kirtiman sir, good evening.
Good evening, Dr. Kirtiman. कैसे हैं आप?
आप कैसे हैं?
Please start, Radhesham sir.
नवीन सर को बता दें एक बार.
Naveen sir, we are starting now, sir.
Yeah, sure. Please start.
हाँ सर, गुड इवनिंग.
Good evening, everybody. और
good evening,
कीर्तिमान
doctor.
कैसे हैं आप?
हाँ बस बढ़िया है सर. गुड इवनिंग सर.
Good evening. बढ़िया. Nice to see you.
Same here sir.
Yeah, we are live now.
Okay.
Good evening, doctors. Myself, Radhesham Pandey, on behalf of LKM Laboratory Limited, India's fifth largest company. I welcome to the digital platform. So today debate on antithrombotic debate. So today our moderator is Dr. Naveen Garg sir from SGPGI and Dr. Satyen Tiwari sir from Ford Hospital and Dr. Ashish Jha sir from Ram Manohar Lohia Hospital. Dr. Kirtiman sir his own clinic and Dr. Neeraj Biryani sir from Kanpur. So I welcome all the panel members with our moderator and I hand over the baton to Dr. Naveen sir to do the proceedings.
Thank you, Radhesham. And good evening, everybody. At the outset, I'm really grateful to Alchem Pharma and especially to Radhesham for organizing this important debate session. And I always like to participate in these sessions because I always learn few points from these sessions. So in this particular session, we will have two discussions. First will be on the antithrombotics and second will be related with the antiplatelet agents. So we have a very good panel and I welcome Dr. Ashish Jha, Dr. Kirtiman, Dr. Neeraj Biryani and Dr. Satyen Tiwari. And we have this expert panel. So the thing will be, first I will present the introductory slides and give the introduction to that particular case. Then one case will be presented, then we will have an open discussion with all the panel members. And same will be repeated for the second case. So without wasting time, I will go to the first presentation, that is for the antithrombotics. So now I will like to share my screen. So can you see my screen?
Visible, sir.
Yeah, okay. So as we all know that the atrial fibrillation is a very common problem and it's a global problem, and India is in the yellow zone. Yellow zone means intermediate prevalence, and we have a lifetime risk of atrial fibrillation 1 out of 3 individuals. So out of 3, 1 will develop atrial fibrillation in his lifetime. And AF increases with the increasing age. And it is responsible for 20 to 30% ischemic stroke and 10% of the cryptogenic stroke. And another important thing is up to 90% of recurrences are asymptomatic. And traditionally, vitamin K antagonists are used for the prophylaxis and they are quite effective. But yes, there are certain problems with these agents. They have a narrow therapeutic window. And we need to do frequent laboratory monitoring for the INR, and they have a slow onset and slow offset of action. And there are a lot of drug and drug interaction, drug and food interaction, and bleeding complications are also quite a lot. And despite having everything, inadequate anticoagulation is there in many of patients. And Garfield registry has shown that majority of the patients who are on the vitamin K antagonist, the INR is in the therapeutic range only in 1/3 of the time. So more than two-thirds of time, the INR is not in the therapeutic range. And we have this interesting data. Then when the INR is away from the therapeutic range, the risk of intracranial hemorrhage and ischemic stroke is very high. So because of these limitations, these designer anticoagulants were developed, and initially dabigatran and rivaroxaban was developed in 2008, and then apixaban was introduced in 2011, and edoxaban was introduced in world market in 2015. These are the designer anticoagulants to overcome the limitation of the vitamin K antagonist. They are basically either factor 10 inhibitor like apixaban and rivaroxaban, and dabigatran, which is available, is a factor 2A inhibitor. And there are a lot of advantages over vitamin K antagonist, and you can have a oral convenient dosing. There is no need for any INR monitoring, and most of these agents, they do not require any dose adjustment based on the age and weight. And we have a good evidence supporting these NOACs, and there are very minimal few dietary interaction and very few drug interaction, and can be used even in patient advanced age and with renal impairment. So the today question is, are all NOACs the same? Yes, they are not same because they are different. The dabigatran is basically a direct thrombin inhibitor, factor 2 inhibitor, and the rivaroxaban and this apixaban, they are factor 10 inhibitor. So their basic mechanism of action is different. And dabigatran is a prodrug while others are not a prodrug. Their bioavailability, point to remember, is rivaroxaban has a very difference in the bioavailability with the food. So if you give it without food, bioavailability is only 66%. So it's 100% bioavailability with the food. So they are different. Their renal excretion is different. T half is different. Liver metabolism is different. And this gastrointestinal tolerability is different. So they are entirely different. They are not same. So it is likely that they are not equal in their efficacy, and so some are suited for particular individual. So so today we have to discuss that how to choose NOAC based on our different properties. And somehow we have to balance the risk of bleeding and ischemia. And if we can achieve that, that is the main thing. If you really want to have a very good outcome in patients on oral anticoagulation therapy, you have to touch this antithrombotic sweet spot. And this antithrombotic sweet spot is a balance between the risk of controlling the risk of ischemia and with avoidance of the bleeding. So point for discussion today is that how to select patients for NOAC therapy and which NOAC should be used for which patient, and what should be done when the patient develops bleeding on this NOAC agent, and what are the guidelines. So now I request Mr. Onkar to present the first case.
Okay.
So now I will stop sharing.
Okay, sir. Right. So now here I present the first case, which is on the anticoagulant topic. The case is there is a 69-year-old man presented in emergency department with palpitation. Is a known case of atrial fibrillation and was on warfarin in the past, but not taking warfarin regularly. He has a history of hypertension and diabetes in 16 years and is on medications. He has a history of IHD since 10 years, but only on aspirin 75 mg OD and history of stroke 3 years back. CT scan done at the time showing ischemic changes. His renal and hepatic functions are normal. For several months, his INR readings have been fluctuating outside the therapeutic range. ECG done shows AF. 2D echo shows compromised LV function with EF of 40%. Normal valves, diastolic dysfunction, no clots and vegetation, and carotid Doppler shows minimal bilateral plaque. And current INR is 1.6. So to manage a particular case, these are the pointers available for discussion. So I'd request now once again Naveen sir to request the other panelists to give their opinion how to manage a particular case.
Yeah. Thank you, Mr. Omkar. So basically, this patient was an elderly patient with non-valvular AF and is having hypertension, diabetes, coronary artery disease, and with a fluctuating INR and with LV dysfunction, with some carotid artery disease. So basically, this patient requires anticoagulation. So my question to Dr. Ashish Jha is, how much is the risk of a stroke for this patient, development of a stroke for this patient?
So, sir, as you have already elucidated, he is already more than 65 years, 69 years. He is diabetic, hypertensive.
Ashish, you are not audible.
I'm not audible, sir. Am I audible, sir?
No.
Actually, voice is a bit low. Can you use earphones or?
So Dr. Neeraj is there? Pandeyji?
Neeraj sir is there, sir.
So I request Dr. Neeraj to answer this question that how to assess stroke risk for in patients of atrial fibrillation and how much is the risk for this patient?
Sir, we use the Chadwell score to assess the stroke of a particular patient with paroxysmal or persistent or a new onset AF, and depending on the score, if the score is 2 or more than 2, then definitely we have to go for anticoagulation, and if it is like 1, then we can then again it depends upon the discretion of the the treating physician to give or not to give anticoagulation. And sir, so it depends. We also take which is the scope of and depending on the risk of the patient. But whatever the score, it should not
Neeraj, your voice is breaking. Are you?
Yeah, breaking. Yeah, breaking.
Yeah, your voice is breaking. If you are inside, try to come outside.
I think if Ashish sir is once again online, so can you try once again?
Ashish, are you? Can you hear me, Ashish?
I can hear you, sir. Are you
audible, sir? Yeah. Audible, sir.
Okay.
Am I audible, sir?
Yeah. So Ashish, how much is the stroke risk for this patient?
Sir, this patient's stroke risk will be high because he already, amongst Chad's score, he already has a past history of stroke. So 2 points will always be is already there. He's a diabetic, hypertensive. 2 more points are there. Then he has vascular disease also. His EF is low. He has his CHF is also there. At least his EF is low. So he'll have at least
So I think he made a very good point that this patient is having a high Chadwick score. So this patient must be anticoagulated. There is no question about it. And before prescribing anticoagulation, would you like to calculate some other score also?
It's a bleeding risk should be assessed. Like has blood score is there.
Yeah.
By that we can assess his risk score. His whether to start it or not will depend more upon Chad's VASC. Has blood will be more about bleeding risk and taking prevention.
So if you just consider this patient as a whole, so if you consider this patient, I think this patient is in favor of anticoagulation because this patient has high Chadwick score. And how much will be the Hess blood score for this patient?
So hypertension is there and has blood. Other elevated liver enzymes and other structures, it will be around 2 or 3 is there, but again, like what I think, whether to start anticoagulation or not is more dependent upon Chad's VASC score. Has blood will not be, even if the has blood is high, we'll have to start him on anticoagulation, put him on anticoagulation.
Dr. Neeraj, I think now the thing is very clear that this patient must be anticoagulated, and
Yes,
this patient had fluctuating INR in the past. And what is the relationship of fluctuating INR on patients on anticoagulation?
Sir, fluctuating INR is a difficult situation we often face in patients who are on vitamin K antagonist. And these patient, I think these are the patient who will be benefited with NOACs if we switch because Levi INR is one of the component of the Has-Blood score. It increases the bleeding risk, and also the patient is under anticoagulated, then there is a risk patient is risk of bleeding. So we need to prefer NOACs in such patients.
So this patient requires anticoagulation, and there was fluctuating INR. So I think he has to be on NOAC. So we have to switch this patient to NOAC. There is no doubt about it. So now, Dr. Kirtiman, can you tell us how will you choose a particular NOAC for this patient? Which NOAC will you like to choose for this patient?
Sir, currently we are using, am I audible properly?
Yeah, yes, properly audible. Yeah.
Currently in India, we are having 3 NOVACs, which we are using in day-to-day practice. One is dabigatran, rivaroxaban, and apixaban. And they don't have any head-to-head trials, so it's not quite wise to say that which is better above other one. But still, there are indirect comparisons are there. And these molecules have their own benefit, and there are pros and cons are there. So it depends upon patient to patient and the characteristic of the patient by which we go and choose NOVAC. For NOVAC, I will like to say that all these 3 are better than warfarin, because warfarin, as we all know, that there is a problem is with time in therapeutic window. Only 30% cases who take properly also have the evidence that they are properly protected from the stroke. So it's not wise to use warfarin, as well as especially in those cases where we have the Levi INR issues, and the issues of INR monitoring is also a very big issue. So we all having 3 molecules. I can preferably I will go with apixaban, which I am using in most of these cases. Dabigatran 150 milligram is also a very good option, which we give in BD doses. In the rivaroxaban, this will be my third choice, because there are so many details are in these molecules. Why will I choose them? Because of the effectiveness and safety of the molecule. It depends upon the efficacy and safety of the molecule. So dabigatran 150 milligram and apixaban 5 milligram BD are the comparable ones. So I will choose in between the two molecules first.
But you said apixaban. Why apixaban is your first choice? Why not dabigatran?
Dabigatran, sir, this is my personal choice. And one more thing, the GI irritability and the GI bleeding is much more common with dabigatran as compared to apixaban. Secondly, the problem of it's also approved. It has been also approved in the end-stage renal disease. Apixaban is also means approved for that indication also. And the least side effects are I've seen with the apixaban. Preferably, I'm using both the molecules, not the biasing of over one molecules, but both the molecules are good. If you compare head to head, also means indirectly comparisons are there. So almost similar molecules are there. There are some points in favor and some points again. Dabigatran 150 milligram. Preferably, I have seen so many prescriptions that they have given 110 milligram of the BD dosing. So many prescriptions I have seen, and that is not effective for. So there are there are two options: 110, 150. Most of the physicians are going with 110 milligram BD. That is not effective. If you are giving the full doses of 150 milligram, or give 5 milligram BD of apixaban.
That is okay. Dosing is okay. So, Dr. Neeraj, do you agree with him that the apixaban should be the first choice for this patient?
I think for stroke prevention, this dabigatran is effective, sir, as compared to this. Is more effective. And sir, although I agree with Dr. Kirtiman that it depends upon the physician, the treating physician also, and his experience, but there's no head-to-head comparison over one drug over the other. But in this particular patient, sir, with this labile INR, sir, I will also go in this elderly patient also, sir, 69-year-old, and with a lot of comorbidities, and the patient is also was taking this aspirin. So, sir, my preference again will be this apixaban, sir.
Dr. Ashish, what is your opinion, Dr. Ashish? Yeah. Ashish, can you hear us?
Trials which have compared. Yes, sir. I can hear you.
Yeah. So, what is your opinion? What is your NOAC of choice for this patient?
So for me, the opinion will be opinions that Dr. Kirtiman, what he has suggested, told is like I also agree with him. The reason being that it's true that there is no head-to-head.
Your voice is not clear.
But when compared to warfarin,
can you speak closer to your mic? Can you speak closer to your mic?
Okay, sir. Am I audible, sir?
Yeah. Now you are audible.
Okay, sir. So I agree with Dr. Kirtiman's opinion. I am the same opinion, sir. It is true that this patient there with there is no head-to-head comparison between different NOAC with a good time in therapeutic range when it is compared with NOAC. These two drugs, like apixaban at 5 milligram twice daily dose and dabigatran at 150 milligram twice daily dose. These two doses have been superior in terms of efficacy. So, if for prevention of stroke, these two doses will be my first choice. Rivaroxaban and edoxaban. At the same time, concern because this patient has raised Has-Blood score also. So, in terms of safety, 5 milligram BD dose is superior to warfarin. and 110 milligram BD dose of dabigatran is superior to warfarin. But 110 is dose, if we choose, it will be less, it will be inferior to, or it will not be superior to warfarin. So one drug which has both higher efficacy and lesser side effects will be apixaban. So if I have to choose one drug, it will be apixaban. My second choice will be, as Dr. Kirtman told, 150 milligram BD twice daily dose of rivaroxaban, and twice daily dose of dabigatran, and the third choice will be rivaroxaban. But again, one
Okay.
may be totally justified in choosing any
So,
of the three options, because they'll
Dr.
be better,
Ashish is in favor of Dr. Ashish is in favor of apixaban. So, Dr. Satin Tiwari, can you hear me?
Sir, yes, sir. Good evening, sir.
Yeah, Satin. What is your opinion?
Sir, I think as you showed the slide, first while I choose the NOAC, I will see the LFT renal function test. If these are normal, and of course,
These are normal. These are normal.
These are normal, so I think I don't hesitate. Whatever is available and cheaper to patient, if it cost is not a factor, first thing I will just do that. Second thing, compliance of the patient also I will discuss. And third thing, I will discuss the slightly high bleeding risk with the dabigatran as discussed in the panel.
So
yes,
yeah. Please go ahead.
Yeah. So because here Hasbled is also 4. So and Chadwell is also I think here higher 4 or more than 4 I think. So probably I will keeping the bleeding risk also in mind. I will choose first apixaban, because even in if you see chronic kidney disease or even some GI bleeding patients, apixaban is slightly safer and compared to dabigatran. So definitely I will go with the apixaban first after discussion with the patient. And second thing, if I will follow the patient, whether is there any bleeding risk or any stroke or further any renal function or LFT is deteriorating or not over the period of time.
So, so panel is in favor of apixaban, followed by dabigatran, and then rivaroxaban. But my opinion is little different. I will consider one more aspect for this patient. I will consider the financial status, status of this patient, because apixaban is quite a costly molecule, and it will cost maybe 8 times or 10 times of the cost of the dabigatran. So that should also be considered. And considering clinical profile of this patient has got high Chadwell score, and Hasbled score is also little high, but his age is just 69. He is not 80 plus, and renal functions are normal, and hepatic functions are also normal, and there is no any history of any bleeding in this particular patient. So he is not of that high bleeding risk patient, and if his financial status is okay, then even then I can consider dabigatran. It's not a bad molecule, and if yes, patient is having renal failure, age more than 80 years, and history of bleeding, then I can consider apixaban. Otherwise, dabigatran will be as good as apixaban, and maybe even as good as rivaroxaban. So my opinion is little different. So I will consider his financial status also, and then we'll take a final decision. So any comment from any other panel member regarding this?
I think your choices and reason for that is very correct, because finances are important. If we write a drug which patient cannot take, then it will not work. But if finances is not an issue, then maybe like apixaban may have a little edge. But otherwise, finances, real life, it is a more important issue. So
because you see, this drug has to be taken lifelong. It's not for 10 days or 15 days or maybe for 3 weeks or 4 weeks. It's for life. So if patient is not having good financial status, there is no point in writing costly molecule. So
Yes,
you have to
rather
be.
Yes, sir. There is a study that if compliance with NOACs is less than 80%, the effect, the beneficial effect is lost. So like therapeutic ranges for them, the compliance is also important for NOACs also. So that may be one of the things that is listed, sir.
So now, Dr. Neeraj, suppose if patient has been prescribed with NOAC and maybe on prescribed with apixaban, as you say, and developed bleeding on apixaban, how will you treat that situation? Bleeding in this patient on apixaban.
Sir, we have to treat. There is no currently any antidote, particular antidote available for that. So we have to treat the patient conservatively. We have to hold the apixaban and give blood transfusions. Try to reverse the anticoagulation by giving FFPs, and this is the only way we can treat if the patient is on apixaban and develop bleeding, sir.
So Neeraj, you made my point very clear that this is one of the main limitation of apixaban, because you don't have any antidote for apixaban. If patient develops any life-threatening bleeding, you have to just manage him conservatively. You don't have anything in your hand. Just for FFP and this prothrombin complex concentrate, if it is available, that too is not available everywhere. So that is one of the main limitation. What is your opinion, Dr. Ashish, regarding this?
This is a good point, and in India, Andexanet alpha or other serapinta, those are not available. But practically, sir, even for dabigatran, getting the drug on time and price becomes a major limitation. So, even if there is a bleed on dabigatran, we seldom use their antidote because it's very costly, and often when it is needed, it is not available.
No, it is costly. That's okay, but not anything which is not available. And in case of life-threatening emergency or bleeding, you cannot do anything with apixaban. And at least you have something in your hand actually with dabigatran and rivaroxaban, that something can be given to the patient to save the life. So on the one hand, you can save some money, and on the other hand, you have something for the management of bleeding. Yes, patient has to pay for that. So that is the, actually you have to balance out everything. And Dr. Tiwari, what is your opinion?
Naveen sir, just to interrupt, sorry sir.
Yeah.
Ashish sir just raised the point of antidote being the cost point of view. So one thing like to add over here, sir, Alkem being a responsible company, if the patient on Dabiclot suffers accidental bleeding, so we reimburse the of both the vials of antidote, which is 1.6 lakh to the patient.
So that's very good point. So Dr. Ashish, so Alkem is reassuring us that in case of any bleeding on dabigatran, they will provide this antidote free of cost. So now what is your opinion?
But so the patient has to be on Dabiclot.
Yeah, that's right. If it is so, I'll put most of my patients on Dabiclot, provided they make it available. And because second is that often we don't get it also. So if 1 or 2 vials are available at least in 2-3 places and they reimburse, then it will be a major incentive to write such a brand. Which can
Mr. Onkar is assuring us, and Radheshyamji is already in the panel, and he is responsible whatever they are saying. If they are saying that this thing is available and they will provide us free of cost, so if that thing is available and they will provide without any cost, then what is the harm in using dabigatran for all our patients?
So just to elaborate, sir, there is a toll-free helpline number wherein doctor has to call the number and the antidote will be delivered to the doctor by the originator company, not by Alkem, because the antidote belongs to the Boehringer Ingelheim company. So after the patient pays the bill, then we reimburse the amount to the patient.
So something is there and something is there in the emergency without any burden on the patient pocket. That's very good, and I appreciate the effort of Alkem for making this thing available to the patient and for the service. So Dr. Tiwari and Dr. Neeraj, what are your opinion now?
Sir, I think Boehringer, the molecule is Pradexa, and this also reimbursed. This give the one, I think, one-time antidote free.
Yes.
And I don't know, they are telling it's a one-time or multiple time. It's a one-time free from Boehringer also.
Yeah.
So,
but their molecule, they are marketing by the name of Pradexa.
Yeah.
Which is costlier than the Alkem molecule, Alkem brand, Dabiclot. So, and they will also provide the same antidote.
That's the original molecule, okay? So that was the first molecule. So,
that I agree.
And I think antidote you are borrowing from them again, probably.
Yes, yes. Because you are bioequivalent with the innovator brand. That is the reason, sir.
So, what is your opinion, Dr. Neeraj? Dr. Neeraj, can you hear me?
Yes, sir. Yes, sir. I was saying if they are assuring that they will be reimbursing the price of the antidote, then I think then we can definitely put the patients who will be benefited with Dabigatran, we can put the patient on Dabiclot in that case. And because the price will be less initially, they have to pay less, and they'll be getting, if at all there is bleeding, so they'll be getting the antidote, and the Alkem people, they are promising that they'll be giving the reimbursement for the antidote, which is very costly.
Sir, we have already get it done in Delhi. One case has been happened till now. We have already reimbursed, sir.
So I know about this fact. So that's why this thing should be promoted, and I request all the your company executives, they should propagate this thing, that this thing is available and can be used without any concern. So this, all the physicians should know actually, na? So they have a fear. So they have a fear that this thing is not available, and if it is available, then it will be very costly thing. So this is on the part of the company to give information regarding this fact.
Sure, we'll do it, sir.
Yeah. So I think if I summarize this patient is having a high Chadwell score and intermediately high Hess blood score, and without any other major thing, and having atrial fibrillation. So can we consider for Dabigatran, considering the cost of the therapy and considering that this therapy should be lifelong, and antidote against this molecule is available. So if he develops bleeding at any time in his life, that bleeding can be stopped immediately by giving that antidote, and that antidote will be free of cost to the patient. So my choice will be Dabigatran for this patient. And if this patient will develop renal failure, yes, then probably I will switch over to Apixaban. And if renal failure, that too GFR of less than 30, 15 to 30, I will like to use only Apixaban. I will not like to use any other agent. So any comment from any panel member? Ashish?
Agreed, sir. Agreed. Agreed, sir. I agree with
Okay.
what you said.
Yeah. Dr. Neeraj?
Yes, sir. I agree, sir. What you have suggested.
Dr. Saten Tiwari?
Yes, sir. Yes, sir. Right, sir. Very right.
Dr. Kirtiman?
Yes, sir. I agree with all this. First, I would like to congratulate Alchem Pharma for this good initiative. And as you rightly said, that they should inform each and every person, each and every doctor about this good initiative that they are giving it this antidote therapy for free of cost. And as I said in my opinion also, that 150 milligram BD is equivalent to apixaban 5 milligram BD, and there are additional benefits of having an antidote available, and that is also free of cost available. Then we should consider dabigatran as our choice.
So now I think we can close this patient, and now we can go to the second patient. So just to introduce the second patient, I will share my screen again. So as far as the antiplatelet agents are concerned, there are so many agents which are available, and basically three agents are available for clinical practice: aspirin, clopidogrel, prasugrel, and ticagrelor. So aspirin we all know, and we are using them for a long time. And now this clopidogrel, prasugrel, and ticagrelor have been introduced. They are basically either ADP blocker or P2 Y12 receptor blocker. So how to choose between them? So as far as the clopidogrel is concerned, it is basically a product, so require metabolic activation, and it requires time, so it is not immediately effective. And second thing is, it is a irreversible P2 Y12 receptor blocker, and once it is given, you cannot offset the action of this molecule, and onset of effective is relatively slow, and complete inhibition, that is 85% of platelet inhibition, is achieved only after 4 hours. And there is a lot of inter-individual response variability. It is because of either genetic polymorphism or clopidogrel resistance. Clopidogrel resistance is a big problem, and all over world, it has been reported to the tune of around 30 to 40%. And India, we have some data that has reported that clopidogrel resistance is there in about till 20% patients. So to overcome this, we have these molecules. Prasugrel is now available. It is again a thienopyridine derivative, but again a prodrug. But it is very, very potent, more potent than clopidogrel, and it requires only one metabolic activation. So it is relatively rapid in onset of action. It is effective within 30 minutes of giving this drug. But the point again is, it is irreversible agent. Once it is given, you cannot overcome that thing unless the effect is over from those platelets. And it has a very long duration of action, 7 to 10 days. So this prasugrel basically more effective, relatively rapid onset of action, but it is irreversible. We have good data for this molecule. I am not going into the detail of this. So basically, this trial has shown that it is more effective than clopidogrel, but at the risk of higher bleeding risk. So basically, there is a black box warning regarding this drug, that dose adjustment is required in few patients, and below 60 kg or more than 75 years of age, one should not use it, and it is contraindicated in patients who already had any ischemic stroke, and CABG cannot be done at least for a week after giving this molecule. Then this ticagrelor was introduced. It is a non-dihydropyridine ADP blocker, and it is a very potent antiplatelet agent. And the important point is its action is reversible. Very rapid onset of action and more rapid reversal is there in 3 to 5 days. And we have a very good data from the Plateau trial that it is better than Clopidogrel. So now the question is, which oral antiplatelet agent to choose for particular patient? So now I request Mr. Onkar to present the second patient.
Shall I present the screen, sir?
Yeah, sure.
So coming to second case, which is on antiplatelet. The second case is about a 52-year-old male who comes in emergency department complaining of a sudden onset of chest pain since 1 hour. The pain was typical of cardiac origin. He was smoker, non-diabetic, history of hypertension. ECG shows extensive inferior wall MI with positive cardiac biomarkers. His BP readings are 130 by 70 mm of mercury, which is normal, and pulse is 70 beats per minute, regular. The patient is ready for intervention. And this is the ECG of the particular patient. So the clopidogrel loading dose was given to the patient, and after 72 hours, patient again developed chest pain. Angiography done again and shows stent thrombosis. So is it a case of clopidogrel resistance? So with this, again, I would request Dr. Naveen Garg to take back to the case and ask the respective panelists about their opinion.
Yeah, thank you, Mr. Onkar. So this patient is basically a patient of inferior wall MI who was treated with the primary angioplasty, and he was on aspirin and clopidogrel and develops stent thrombosis. So my question is, why this patient developed stent thrombosis? So what are the risk factors or predictors for stent thrombosis? Dr. Ashish, can you tell us?
So in this case, he's not a diabetic. His other risk factors we don't know, but ACS in itself, especially STEMI, these patients have a high thrombotic burden and they have a high risk of peri-PCI events, especially initial 48 hours. So this is a subgroup where actually it has been very clearly documented that probably in the beginning itself, the other two antiplatelet agents would have been better choices, ticagrelor and prasugrel. So in such cases, who present with ACS, the clopidogrel resistance is also high, and even otherwise they have a high risk of thrombotic event recurrences. So stronger antiplatelet agent should be used.
So Dr. Saten Tiwari, what will you do for this patient? Now this patient has developed stent thrombosis. He is still in the hospital. So how will you treat this patient?
The patient is having stent thrombosis. If he is hemodynamically stable, again after informed consent and telling the risk pros and cons of the stent thrombosis, so we'll take the patient definitely into cath lab for reintervention, and I will definitely change the drug because he was loaded with the clopidogrel. So probably I will use either prasugrel or ticagrelor, preferably prasugrel. And maybe I would first see the angio, then I will load probably after the angiography.
So now I think as I can understand your point, you will like to treat him with angioplasty, okay, and you would like to change the DAPT. That's
yes,
true?
Yes, sir.
So angioplasty, I think all of us agree that all patients of stent thrombosis should be treated by immediate angioplasty. You have to open that artery, otherwise patient will not survive. So that's true. Okay. So now the question is change in the antiplatelet regime. So patient was already on aspirin and clopidogrel. So which agent now you will like to give him in the cath lab and afterward?
Sir, I would prefer, suppose if it was a long lesion, heavy thrombus burden, then definitely I will go with the prasugrel. Second cause, I would see if it was under deployed stent and there was some residual something. So all things keeping in mind, I will load with the prasugrel, sir. Because it will be
Why prasugrel? What is your basis of using prasugrel? Why not ticagrelor?
Sir, as just we discussed in your slide also that it is very potent, very potent.
Yeah.
So probably multiple. It's a case of single stent thrombosis, but still, if available, suppose ticagrelor, and because of potency, I would just if there is no bleeding, ongoing bleeding or bleeding risk, then definitely I will load with the prasugrel. Otherwise, if there is some bleeding or minor wound something, then I will go with the ticagrelor.
And what is your opinion, Dr. Neeraj?
Sir, I agree with Dr. Saten that in this particular patient, we have to re-intervene with angioplasty, and re-intervention is needed, and we have to change the antiplatelet. And I actually, sir, I've got more experience with ticagrelor. So I would have given actually ticagrelor to the patient, reloaded the patient before shifting to the lab. Again, reloaded the patient 180 milligram of ticagrelor, sir.
Okay, and then you will like to continue with the ticagrelor.
Ticagrelor, yes, sir. 90 VD, yes, sir.
Okay, so your choice will be aspirin plus ticagrelor.
Yes, sir. Yes, sir.
And how much aspirin would you like to? Initially, he was on 150 milligrams. So now you are switching to ticagrelor, stopping clopidogrel and switching over to ticagrelor. So how much aspirin would you like to use now?
Sir, 75 milligram.
Okay, that's true. Why 75? Why not 150 milligram?
Some more dose. It has been shown that it inhibits the antiplatelet effect. It reduces the antiplatelet effect of ticagrelor, sir. The more dose of aspirin.
Yeah. So that's the point. So, Dr. Ashish, what will be your choice?
So, I would also use either of the two, but I would prefer prasugrel based upon data from ISR React 5 trial.
So if you consider actually this ISR React 5 trial, actually there were so many points which have been quite controversial. Actually, in that particular trial, this prasugrel was given at what time? During the procedure or before? Before the preloading was done with the prasugrel or with ticagrelor?
Preloading with ticagrelor, it was prasugrel only, sir, but I'm not sure. In this trial, what it showed was that thrombotic events and ischemic events were lesser with prasugrel, and bleeding events were not increased in prasugrel arm. They were numerically lesser than ticagrelor. But
actually, even if you go by the this ISR React 5 trial, this is the only one study which have shown superiority of prasugrel over ticagrelor, but there was some controversial methodology which is not acceptable to all the physicians. So, and we have such a good data with ticagrelor. So why you are afraid in using ticagrelor? Because we have much more data in favor of ticagrelor. Much more patients have been treated with ticagrelor than prasugrel.
Sir, like it depends upon center to center experience. Like we have been using prasugrel for a lot of patients, and we have been using almost 50% of cases on ticagrelor also. Almost similar experiences there. And even bleeding wise, we have not published it, but we have not seen much difference in either in the two. So effect wise, it is more potent. There is no doubt. Stent thrombosis is the case which has highest risk. It's not first MI only. It's STEMI who has developed stent thrombosis. So if I have to use, and we know that bypass is not the option. None of these patients will go to bypass. So surgery, and that is not a concern. So if I have to use, I'll use the most potent antiplatelet drug. So ticagrelor, there is no problem, but why not prasugrel?
And Dr. Neeraj, what is your say on the side effects of ticagrelor versus prasugrel?
Sir, actually, my experience with prasugrel is very limited, sir. And with ticagrelor, luckily, I have yet to see any devastating bleeding complications. And I'm lucky enough that my patient have not experienced it, because then it becomes a very catch-22 situation for an interventional cardiologist if patient starts bleeding. So, so sir, with this ticagrelor, a few patients definitely they complain of this breathlessness, dyspnea, which is because of this adenosine mechanism. And sir, other than that, there are some reports of this ventricular ectopics or premature VPCs can be seen in patients with ticagrelor. Sir, other than that, few patients definitely in my OPD, in my practice, I have seen the patient complaining of this skin petechial hemorrhages, sir, skin bleeds. Quite a few patients on ticagrelor, they complain of this skin bleeds, and they are very they are too much complaining of that. Then in that case, sometimes I have to shift after 3 months of post PCI. Then sometimes, sir, in that case, I had to shift to Clopidogrel with aspirin. But otherwise, I try to convince them, and I try to continue at least for 6 months, sir. I try to continue with ticagrelor. So, sir, this is my experience which I wanted to share, sir.
Yeah, I agree with you that that ticagrelor is has got a much stronger data in favor of using in patients who are developing stent thrombosis or in patient with even with primary PCI. So as far as the bleeding complications are there, they are much more common with prasugrel. I have seen patients bleeding like anything, and then you cannot do anything because its action is irreversible. And with ticagrelor, its action is actually reversible. Once you stop it, the effect is start bleeding complication will start decreasing actually. So that is my point. So my approach will be little different for this patient. So I will like to consider the procedural factor first. So if there is no under expansion and proper coverage of the lesion is there and good sizing was there, then I will consider it as a resistance. And to my opinion, most of the stent thrombosis, they are all procedure related. They are not related with your agent. So first, I will like, whenever I will have patient like this, I will consider all these factors, and if provided, if available, I will like to do OCT in those patients to know any factor which is responsible, procedural factor responsible for stent thrombosis. If it is not there, I can continue, and I am telling you my practice in patients in having stent thrombosis. Most of the time, I continue with the original agent. I do not switch to another agent. because most of the time I find some procedural factor related with the stent deployment or stent under expansion or inadequate coverage or some dissection proximal or distal to the stent. But yes, if there is no complication or any procedure related problem, then my practice will be I will switch over to Ticagrelor. I will not use Prasugrel because Ticagrelor is now quite cost effective, and bleeding complications are relatively less than the Prasugrel, and we have strong data, much strong data in favor of Ticagrelor than Prasugrel. We have only one trial favoring Prasugrel in comparison to the Ticagrelor. So any difference of opinion from any panel member? So now the next question is, what is the aspirin-free PCI? Can we do PCI without aspirin, Dr. Neeraj?
Sir, I cannot imagine doing a PCI without aspirin.
So now that is actually the latest concept which is coming up, aspirin-free PCI, and
Okay.
we have a one good, very small but good trial. So I think
Right.
Dr. Ashish can tell us something about this.
Tycho trial, Tycho Twilight.
Yeah. Who is saying this? Dr. Satin?
Sir, I am saying that.
Acha, okay.
Sir, but practically, sir, it is very difficult. Yeah.
No, actually the concept is, if you use a very potent P2Y12 inhibitor like Ticagrelor, which is very, very potent, then the additional benefit of aspirin is very minimal actually. By adding aspirin, you will add this bleeding complication. It will give you bleeding complication, not of any much efficacy, additive efficacy. That is the basic concept. So if you use agent like Ticagrelor, you can actually avoid aspirin. So we have one trial exclusive done in about 100 or 150 patient asset trial, in which this Ticagrelor was used alone, and aspirin was given just at the time of admission, and then aspirin was not given at all. And in all the study per patient, there was only one stent thrombosis that was of basically related with the procedure. And now we have data from trials like patients with requiring long-term anticoagulation, like Augustus trial and Voice trial, in which patients have to be on antithrombotics. So in those trials, the aspirin was withdrawn after some time, after PCI, and patient were continued on this anticoagulation plus Ticagrelor. Anticoagulation plus other antiplatelet agent, and they have shown that aspirin can be withdrawn. Now we have data from very good trial like Stop DAPT2 trial, Smart Choice trial, Twilight trial, TICO trial, Global Leader trial. In all these, what they did is they used this Ticagrelor and then they stopped aspirin after some time. And they have shown that, yes, it is possible and you can adopt this approach in a high bleeding risk patient. So now the concept is emerging that if you can use Ticagrelor as a stent alone agent, you may omit aspirin and you can omit the these bleeding complications. So do you agree with this concept of aspirin-free PCI? Do you think the future is Ticagrelor alone for even for PCI patient or ACS patient, you can treat your ACS patient with ticagrelor alone? Dr. Neeraj, please.
Sir, this concept is a very novel concept and very it needs to be appreciated also. But sir, as an interventional cardiologist, for first 3 months till the time the endothelialization happens, so I have like I would like to give my patient dual antiplatelets, but definitely considering all these trials and all the data, if the patient is having a high bleeding risk, so even before 3 months, also we can like stop the aspirin. Aspirin has somehow lately it has has been regarded like it has been labeled as a culprit for bleeding complications.
Yeah.
Rather than other agent. Sir, in these trial like the Tyco and Twilight, I think they used a particular DES drug-eluting agent. They used this Orsiro,
Latest third generation.
Yes,
Orsiro or
Orsiro they use,
yeah.
sir.
Yeah.
So
That's true. Yeah, you
so,
are right.
sir,
If you use potent antiplatelet agent like ticagrelor with third generation drug-eluting stent, thin strut and polymer free or very friendly polymer, then they have shown that yes, you can withdraw aspirin.
yes.
So that is a novel concept, and I think ticagrelor will go a long way in this regard. So, Dr. Ashish, what is your opinion?
Regarding sir aspirin free PCI.
Yeah.
So it's like data is it's an interesting trial. We need more data before like as we previously discussed, like unless we have bigger data which confirms this, at least for initial 1 to 3 months we would like to give him dual antiplatelet and then followed by ticagrelor alone.
Yeah, so that is one of the major advantage of ticagrelor, that you can use aspirin low dose 75 with ticagrelor, and then you can stop this aspirin after 3 months, and then you can continue with the ticagrelor for maybe for 2 years, and then you can even stop this ticagrelor and can switch over to aspirin. So that's a very good concept, and I think the future is there for this concept. And Dr.
Yes,
Satyen Tiwari, what is your opinion regarding this concept and this ticagrelor therapy?
Yes, sir. I think this is a newer concept. I think even prasugrel has also been tested in ASSET pilot study. So this concept is being applied in newer antiplatelets. And because we are seeing a lot of very high risk bleeding patients, so probably it will be very good for the patient's outcome and lesser morbidity over the years.
So I think if I conclude this patient, I will like to do PCI, and I will like to first consider the procedural factor. Then I will like to switch over to ticagrelor plus low dose of aspirin, and then after I will like to continue this aspirin plus ticagrelor at least for 1 year. Then I will decide about the future antiplatelet therapy. So now I request Mr. Onkar to take up the question from the chat box.
Yes, there are some questions from the audience also.
Yeah.
I'll take one by one.
Yeah.
So the question is coming as told by doctor in the dabigatran part that 150 mg should be the recommended dose for AF. But currently I am using 110 mg. So am I underdosing my patients with 110 mg?
So Dr. Ashish, can you answer this question?
Yes, sir. Sir, if a patient has like GFR which is more than 50 and his age is less than 80 or 75 years, then and he doesn't have any high risk for bleeding, probably you are underdosing. If otherwise, like if these factors are present, then doses of 110 may be justified. Otherwise, in a routine case without these risk factors, 150 BD is the correct dose.
Yeah, so I agree with Dr. Ashish. If you really want to use dabigatran, and if there is no risk factor as he enumerated, then I think one should use a proper dose, that is 150 milligram BD. There is no point in using 110 milligram BD. It is as good as nothing. It will add some bleeding complication without any efficacy. So
there is one more question, sir.
Yeah.
My current patient of AF is on dabigatran, and he is about to go for a PCI.
Okay.
So post PCI, should I add another antiplatelet, or what should be the approach?
So now I think, Dr. Neeraj, I think you have answered this many of these things. So can you answer this question?
Sir, with dabigatran, sir, post PCI, it depends upon the indication also for the PCI, if it is whether it is done for a stable angina patient or for a acute coronary syndrome patient. If it is done for a acute coronary syndrome patient, then a triple drug will be given, triple drug therapy will be given for at least.
I
think there is a net issue at
yeah.
After that, we need to shift to
I think there is some net problem. So I request Dr. Satyen Tiwari to answer this question. Dr. Neeraj, yeah. Can you hear me? Yeah.
Yes,
Suppose this patient, there are two scenarios. One is patient is on dabigatran and developed acute MI. Okay. So how to proceed? And second is patient developed angina, and then how to proceed?
Yes, sir.
Yeah.
Yes, sir.
Yeah. So take the first scenario. Patient on dabigatran developed acute anti-wall MI.
Yes, sir.
So how will you manage that patient regarding antiplatelet therapy?
Regarding the antiplatelet therapy with dabigatran, sir, we will load the patient, sir, with the antiplatelet agents, dual antiplatelet. I will use a Clopidogrel with aspirin, and then, sir, we will do the PCI. Post PCI, we have to continue the triple therapy for at least, sir, a month or 28 days. And then we have to shift to Clopidogrel with dabigatran, and we need to continue that for 6 months at least. And then, sir, after that, we can shift to this dabigatran alone, or we can continue till 1 year, and then we can just after that for AF, like we just continue with the anticoagulant, sir. We stop the antiplatelet.
So now your point is well taken, that first thing is, in such a scenario, don't use ticagrelor and prasugrel. Patient on oral these NOAC developing acute MI, so don't use those very potent agent. Otherwise, patient can have severe bleeding that may be out of control. So I agree with you, totally agree with you, that patient should be given aspirin and Clopidogrel, and then PCI should be done. Then I think patient should be on triple therapy. We cannot stop dabigatran. We have to continue dabigatran with aspirin and Clopidogrel, and this triple therapy should be given for at least for 4 to 6 weeks. Then you can stop this aspirin, then you can stop aspirin and you can continue. You have to continue with clopidogrel and dabigatran, and that you have to continue at least for 1 year. Then you can stop even this clopidogrel, and you can switch over to aspirin plus dabigatran. And now the second scenario is patient on dabigatran developed stable angina class 3. Then how to proceed? Dr. Ashish, can you tell your opinion?
Sir.
Yeah, Dr. Kirtiman, yes.
Sir, should we continue with dabigatran or should we switch to warfarin? Because I think Novak is not indicated for the first 1 month of after if we are going for ACS treatment and if we are doing angioplasty. So whether we should shift to warfarin or we should continue with triple drug with Novak only.
No, you have to continue with Novak because this warfarin is not good for triple therapy, because we have data from the this Augustus trial that and it is clearly in favor of Novak. You have to continue with Novak triple therapy with aspirin, clopidogrel plus 1 Novak. Then you can stop aspirin after 4 to 6 weeks. So there is no point in using vitamin K antagonist because there are so many drug interaction, drug food interaction. So many things are there, and patient will be already on multiple drugs after PCI. So I don't think this warfarin or acetrom has got any role for that particular patient. So now the second scenario. So Dr. Ashish, can you hear me?
Yes, I can hear you.
Yeah. So now the second scenario is patient is on dabigatran and developed unstable angina. No troponin increase. It is just class 2 or class 3 angina.
Yeah.
So how will you proceed with DAPT?
If it is not getting control with
non-ACS.
Non-ACS. Okay. Non-ACS, we would first like to see the angiography, like what it shows. Then only further treatment will be decided.
So suppose the patient is having double vessel disease, discrete lesion in LAD and RCA.
Okay. So this patient merits angioplasty. Probably CABG will not have any advantage. In this case, even like the major difference, what you told, like for AF indication, he needs to be on NOACs, which maybe like same may be continued because there is no problem with the NOAC. It's a different event. Now the duration of dual antiplatelet will be kept minimum in this case. So like just pre-procedural loading with aspirin and like ticagrelor or clopidogrel, especially clopidogrel will be better. For maybe like after procedure, aspirin need not to be given. Only P2 Y12 inhibitor, preferably clopidogrel plus this thing dabigatran for at least a month. If there is no high risk for bleeding, then 3 to 6 months also it can be increased. Beyond 3 to 6 months, it has to be only dabigatran. So the main difference will be, sir, I think that shorter duration of dual antiplatelet and aspirin for the shortest time.
Yeah. So Dr. Kirtiman, do you agree that patient can be given ticagrelor? Dr. Kirtiman, can you hear me?
Yes, sir. Yes.
So Dr. Ashish said he can use either ticagrelor or clopidogrel along with aspirin and dabigatran. So do you agree that you can use ticagrelor in this patient?
No, sir, I will go with clopidogrel because ticagrelor will have more bleeding and it's not indicated for the, especially triple drug combination, it is not indicated till now. And I'll go for the, as Ashish sir said, that for 3 to 6 months, if there is no bleeding, I'll go with the, especially in the first month, triple drug. Then afterwards, aspirin will be eliminated from that regime and double drug with clopidogrel and anticoagulant Novak, I will go for 3 to 6 months.
So
And
yeah,
after 6 months, only single anticoagulation.
So the only difference between these two scenario will be the duration of DAPT. Or this antiplatelet therapy. You can stop antiplatelet therapy earlier in patient with stable angina in a non-ACS situation. In a ACS situation, everybody will like to use antiplatelet therapy, good antiplatelet therapy, at least for a year. And in patient with stable angina, you can stop it earlier. So, but in the initial part, I think aspirin plus clopidogrel plus NOAC should be continued. And I will not like to use this ticagrelor and or prasugrel in any of my patient for a triple therapy. So, Mr. Onka, do we have some more question in the chat box?
One last question is there, sir.
Yeah.
One doctor is asking, could
Onkar, your voice has gone.
hello, can you hear me?
Yeah, sure.
Yeah, now it's okay.
Doctor is asking, can you please touch upon the aspirin-free concept, that whether after 3 months aspirin has to be discontinued or after 1 year aspirin has to be discontinued?
Can you repeat this question? I'm not able to understand the question.
The question is,
can you repeat? Yeah.
Doctor is asking, can you please touch upon the aspirin concept, whether after 3 months aspirin can be discontinued or after 1 year aspirin can be discontinued?
So if I correctly understand this question, probably he's like to he's asking that after 3 months of DAPT therapy, if we really want to stop something, then either aspirin or this ticagrelor should be stopped. That is the question?
Yes.
Yeah. So, Dr. Kirtiman, can you elaborate on this?
Actually, he is asking that first of all, that aspirin-free PCI he is asking, and that is a different scenario. That is a different scenario as compared to after 1 year DAPT duration. DAPT duration is a different issue. These are completely
okay.
different issues. So usually in now we are practicing that 1 year DAPT we are prescribing, preferably with the ticagrelor and ecosprin 75 milligram if in the cases of PCI. So we try to continue it for at least 1 year. And after 1 year data is also there, up to 2 years we can continue. There are benefit with ticagrelor 60 milligram have been come. So if you want to continue it, you can continue in a high risk patient for the 1 more year or 6 more months. And then aspirin free PCI is a different thing. That is upcoming, that is the future of whether we should use aspirin from the initially or not. That is a different issue, and now we are not practicing it, but in future it may be there may be aspirin free PCI will be there.
So I think he made a very good point that after PCI or after ACS, DAPT should ideally be given for 1 full year. And if patient is really having bleeding complication, and if you really want to stop one agent after some time, then I think aspirin should be withdrawn, not this ticagrelor or clopidogrel or this prasugrel. Aspirin is the culprit. If you are using a very potent antiplatelet like any of these 3 agents, then I think aspirin can be stopped. I think that is the answer for that question. Do we have any other question?
No, sir. No, sir.
Okay. So I think we had a very good discussion, and we came to some conclusions also that if we really want to use anticoagulation in form of NOAC, dabigatran is a very good choice, and it is quite cost effective, and we have antidote which is available, and Alkem has assured us that they will make it available and will provide to the patient free of cost. So it's a very good agent, and we can use dabigatran as a NOAC of choice in our patient, in most of our patient. And second conclusion regarding this antiplatelet therapy, we reached that ticagrelor is a very good agent, potent agent, and should be used in most of our primary PCI patient or for acute coronary syndrome patient. And third conclusion we achieved that we can stop aspirin earlier if required. And fourth thing, if we really want to use triple therapy in consequences like situations like atrial fibrillation patient undergoing PCI, then triple therapy should be given to these patients. And in those patients, we should not, and we should not use these potent agent for that particular time. So I think we had a very good interaction, and I congratulate Alkem Pharma for this good initiative, for this good interaction. And I also learned so many points from our panel members, and I will like to, yeah.
Sir, just one more
Yes.
point I would like to share, sir. Sir, that ticagrelor is indicated for both the invasive strategy as well as the conservatively treated patients. Whereas the prasugrel is indicated only for patients who are planned for a PCI.
Yeah,
so this
very
is
good
also
point.
one of-
Yeah,
Yes,
yeah.
sir.
So we achieved to some conclusions, and I hope we will like to use all these points for our patient in the clinical management. So I will like to thank all the panel members for such a lively discussion. Now hand over to Mr. Onkar and Mr. Radhesham Pandey.
Thank you, Doctor. Once again, Dr. Naveen Garg, sir, for moderating the webinar very well, and all the panel members, Neeraj sir, Kirtiman sir, Ashish sir, Satyen sir, and all the queries have been solved for the audience, and this is going to help in their day-to-day clinic practice. And we at LKM are always there in your support. Our products are widely available at all the counters like Tikavig, Debiclot. So we will request to please continue your support, and we will continue the same spirit in this debate and other meetings also. Thank you everyone, thank you audience, and thank you panel member and moderator. Thank you so much, sir. Good night.
Good night.
Thank you, sir. Good night. Sir.
Thank
Bye,
you.
sir.
Thank you.
Thank
Good
you,
night.
sir.
Bye.
Thank you, sir.
Bye. Bye. Bye.